into medical school, and I hope that this class is one that is very informative, and interactive as well. So feel free to unmute your mics, ask any questions, etc. All right, so what we'll be covering today is an introduction to anatomy, as well as some of the upper limb bones. All right. We'll be discussing first the anatomical position and the various anatomical planes. All right, so the anatomical position, it provides a reference point for all anatomical description and is related to all anatomical terminology. So any anatomical term you hear is in relation to the anatomical position. Just to describe the anatomical position, the body is upright and facing forward. The arms, as you see here, are extended and to the sides, with the hands relatively next to the hips. The feet are parallel and the toes are pointed forward. Right, so we have various anatomical planes that we use to cut the body into different sections so that we could have different views at different angles or different specimens. Yeah? Could you repeat that? You were breaking.
The session is being.
Hello? Could you repeat that, please? I'm not hearing you properly. Somebody was saying something? No? Okay, I'll continue. If anything, just unmute your mic and let me know. I was saying that we have various planes, and that allows us to separate the body into sections so that we could have different views at different angles, right? So the first plane we have is the sagittal plane, right? And that's this plane here in red. And this cuts the body into a left and a right section, right? Whenever this plane occurs in the midline of the body, is known as the medial plane or the mid-sagittal plane, right? Next, we have the coronal plane, and that's in blue. This is also referred to as the frontal plane because it divides the body into an anterior, a front, and a posterior, which is behind. You might also hear anterior being referred to as ventral and posterior being referred to as dorsal. And the last plane we have is the transverse plane or the axial plane, and this divides the body into superior and inferior sections, or upper and lower sections. Right, this diagram just has each plane on an individual body, so you could properly see its sections.
Quick question. I was rewatching the lecture with Dr. Can't remember his name. But when he was talking about the frontal plane, he said that it divides the body into anterior and posterior, and then he said the same for the sagittal. But because it was a recording, I couldn't ask him if that was a mistake. So I don't know if you could clarify.
I believe that had to be a mistake, yeah. Because the sagittal plane divides the body into left and right, and the frontal is anterior and posterior.
So when you say sagittal plane, that's how we're going to refer to it, just left and right. It doesn't have any other terminology.
No, yeah, just left and right, yeah.
Oh, all right.
Later on, we would see where you have medial and lateral, but that occurs on both left and right sides. But the sagittal plane divides the body into left and right sections.
Okay, thank you.
Cool. Nice. I hope you're clear now.
Yeah.
Okay, cool. Right. I was saying that this diagram just has the different planes on an individual body, so you could properly see the different sections that the planes produce, right? So this is the sagittal plane, and you could properly see that it divides the body into a left and a right, right? The frontal plane divides the body into anterior and posterior, or ventral and dorsal. And the transverse plane dividing the body into the upper part, superior, and the lower part, inferior. All right? Now we just go through some terms of location. All right, so we have origin and insertion. And these two terms refer to points of attachment of a muscle. It's important to understand origin, and insertion when we're discussing muscles, right? So an origin is the point on the skeleton where the muscle begins or arises, right? It's important to know that this point does not move. It's stationary, completely stationary. No matter what contraction occurs in the muscle, the origin remains stationary. The insertion refers to the point on the skeleton where the muscle ends or inserts, or the tendon of the muscle inserts, right? And this point moves. This point, the insertion point moves when the muscle contracts, right? The importance of knowing origin and insertion is because knowing the origin and insertion of a muscle could allow us to determine what action the muscle facilitates. So for example, in this diagram here, we have a bicep. We also have the tricep, but let's pay attention to the biceps, right? Biceps brachii. We could see here is the origin. That's two origins, but let's say on the scapula, the bicep originates. It inserts into this bone here, which is your radius, right? Because we know that the origin remains stationary and the incision moves, when the bicep contracts, we could determine that the incision moving would allow for the forearm to be flexed, to move closer to the arm, right? So knowing the origin and insertion allows us to know the action muscles facilitate. Anything you don't understand, anything you want to repeat? Oh, that's clear.
It's clear.
Okay, good.
Can you check if Serena is here and hearing? Because I mean, when she was trying to ask her question, she was breaking up. So
I'm seeing her in the list of participants. Serena, you want to just indicate if you could hear me? If you could hear me. Let me just ask her in the chat. Um, Give me 1 second, okay?
okay.
Okay, so let's continue for now, and we'll make the recording available for Syrian so that she could view anything that she might have missed. Right, where was I? Right, I was saying that you're hearing me, right?
Oh yeah, I'm hearing. Yeah.
Okay, great. Right, I was saying that the origin and incision allows us to understand the action that a muscle facilitates, right? Right, this diagram summarizes a lot of the anatomical terms that we have to be familiar with to properly understand anatomy, right? So first we have superior and inferior. Superior refers to the upper portion of the body. So if you say something is superior, it's above, right? Inferior is the opposite of that. That refers to the lower portion or lower section of the body. If something is inferior to something, it's beneath it, right? Lateral and medial. Medial refers to near to the midline. So the midline of the body, anything that is near to this midline, we could say is medial, right? Lateral refers to further away from the midline. Then we have proximal and distal. Proximal refers to near to an origin, right? So let's look at the two limbs here, the upper limb and the lower limb. The origin of the upper limb would be in this region here, the shoulder region. So structures that are close to this region are referred to as proximal. And the further away we get from this region, which is the origin, we get more distal. All right. Same thing could be said for the lower limb. This region is the origin of the lower limb. So structures that are close to this region are referred to as proximal. All right. The further away from the origin we get, the more distal you get. Right.
Okay, what if we were talking about sorry for asking this, but I haven't read
It's okay.
enough. But if we're talking about muscles in the neck, would that also apply to proximal and distal? Like further up the neck, it would be proximal, and then for, lower down on the neck, that would be distal.
No, that would
Oh,
be superior and inferior.
in the neck?
Yeah. So like, okay, so hmm, superior and inferior. We use those terms to relate structures, right?
Uh-huh.
So let me see if I could draw something. Okay, so this dot here, right? That line there, and then we have another one here.
Mm-hmm.
All right.
Mm-hmm.
This line above here, which is above this line, we could say that this line is superior to this one.
Okay.
Following, right? And that could be said for any other structure throughout the body.
So the proximal
Right?
and the distal are not specifically for muscles. It's just origin and um the last one.
No, it's not specific to muscles. We could use it for bones as well. But basically any structure that begins, how to describe this? Any structure that has an origin and then extends from that point, right? So structures proximal would be things that are close to or near to the origin point. And things that distal would be referred to things further away from the origin. So
Oh,
moving distally would be moving further away from the origin point.
and this can be said for injuries, muscles, and other structures.
Yes.
Okay, so
Well,
if the injury was near to like the clavicle, if you were describing it, you would say there's a laceration proximal to the breastbone or something like that, or proximal to the breast area, or that's not how that works.
Not quite. We would use superior and inferior in terms of that.
See, now you've lost me.
Think of proximal and distal as more or less specific to the limbs, right?
Oh,
Think about it like that.
okay,
For now.
that kind of helps.
Yeah.
So just
It isn't quite like that, but think about it like that for now. And when I'm going through some of the bones, I'll explain why I said that.
Okay.
All right. Right now we have anterior and posterior. As I said before, anterior, which is synonymous for ventral, refers to the front, and posterior refers to the back or dorsal. All right. Cephalic and caudal. These terms you might hear being used more so in embryology, but cephalic refers to the head, closer to the head. So if something is moving in a cephalic direction, they're moving towards the head. And caudal refers to tail, because in embryological development, at a point the embryo has like a head and a tail region. So that's why it's cephalic and caudal, head and tail, right? Yeah. That's it for this slide. Okay, so this table just summarizes what I would have gone through just now. The only thing I wouldn't have mentioned was superficial and deep, right? Superficial refers to close to the surface of the body. Deep refers to further away from the surface of the body, right? Okay. Right, now we'll get into anatomical terms of movement. All right, so these terms generally used to describe the actions of muscles on the skeleton, right? So the first pair of terms we have are extension and flexion, being opposites to each other, right? So extension, when we say extension, it refers to increasing an angle between two parts of the body, right? So if you look here, we can see this part of the upper limb here is the arm, and this part the forearm. When you're extending the arm or the upper limb, sorry, we're increasing the angle between the arm and the forearm. So this angle here increases during extension. The opposite of that would be flexion. So if you flex your bicep, your forearm would move closer to your arm, and the angle between those two would be decreasing. Right? So flexion refers to a decreasing in the angle between two parts of the body. All right. Next we have abduction and adduction. Right? Abduction, abduction, refers to moving a part of the body away from the midline. Right? So in this diagram, you see the person moving his hand away. That is shoulder abduction. Right? The opposite would be adduction. Right? And that refers to moving the part of the body closer to the midline. Next, we have lateral and medial rotation, right? Lateral rotation refers to rotating a part of the body away from the midline, right? And medial is the opposite. That means rotating towards the midline. These two diagrams have lateral and medial rotation. Lateral rotation of the lower limb, the foot is pointed away from the midline, right? The midline of the body. And medial will be the opposite. The foot will be pointing towards the midline of the body. You can see it here with the upper limb. Medial rotation, the hand moves in the direction towards the midline. Lateral rotation, the hand moves in the direction away from the midline. Right? Any questions as well?
No, I'm okay.
Okay, good. Anybody else?
No, not for me.
Okay, cool. Right. Now we have supination and pronation, right? These two terms are more or less, well, they are specific to the forearm, right? Supination is the action of moving your forearm in the supine position, hence the name supination. Supination. The supine position, if somebody is to lie down in the supine position, they're lying with their back on the floor, right? So they're lying face up. That is the supine position. So movement that would put your hand in the supine position is supination, right? In the supine position, the palm of your hand is facing upwards. How I remember this is think of a bowl of soup. Like if you're holding a bowl of soup in your hand is in the supine position. So you would have that movement where you start from your hand, your palm facing downward, and you're rotating your hand upward. That movement, that motion, is referred to as supination. The opposite of that would be pronation. So you're rotating your forearm in the opposite direction. You want your palm of your hand to now face downwards. Your hand is now in the prone position. The prone position, if someone is lying in the prone position, they're lying with their stomach on the floor. Like if you ever play Call of Duty or anything like that, you would that's a movement that the character does, like going prone, lying down flat on the stomach, right? So any movement that puts the hand in the prone position, that movement, that rotation, is referred to as pronation. All right. Next, we have circumduction. So circumduction refers to really making a circular motion, right? It might be better described as a conical shape because if you look at the entire upper limb, moving in that circular motion actually creates a cone shape, right? But it more or less refers to making a circular motion, a circumference, following a circumference, hence the name circumduction. The rest of the terms we have here are more or less specific to the shoulder, but not 100%, not 100% specific to the scapular, shoulder blades, right? First one we have, well, the first pair we have is elevation and depression. Elevation refers to moving superiorly, moving upwards. So if you shrug your shoulders right now, you're moving your scapula superiorly. You're moving your scapula up. That is elevation of the scapula. And if you have your shoulders shrug and bring it back to normal, that is depression of the scapula. Right? Next, we have upward rotation and downward rotation of the scapula. Upward rotation, this point on the scapula here, which you would come to know as the inferior angle, when that moves in an upward direction, right, outward and upward, that is upward rotation of the scapula, and the opposite, downward rotation. So you're bringing in downward rotation, you're bringing the point, let's call it the point for now, the point of the scapula downwards and medially, right? Upward rotation, the point of the scapula rotates laterally and upward, right? Next, we have protraction and retraction, right? Protraction is moving the scapulae outward, lateral and outward, laterally and forward, right? That is protraction. So if you try to move your shoulders forward, that is protraction of the scapula. And the opposite of that, if you try to bring your shoulders backward, that is retraction, and you're bringing the scapulae closer together, right? So you're moving the scapulae medially. In retraction, that is. In protraction, the scapulae move laterally and forward. Right, now we have inversion and eversion, right? So these terms are specific to the foot, right? Inversion, during inversion, we're moving the foot, or rotating rather, the foot in a manner that allows for the plantar surface, which is the sole of the foot, to face the midline. So you're rotating the foot medially, right? Eversion, the opposite, you're rotating the foot in such a way that the sole of the foot faces outward or laterally. So eversion is more or less lateral rotation, right? And inversion, medial rotation. Next, we have dorsiflexion and plantar flexion. So dorsiflexion is when you're flexing the foot in the direction of the dorsum of the foot, right? Which is the top part of the foot here. So here is referred to as the dorsum of the foot, hence dorsiflexion, upward flexion. Plantar flexion, right, is where you extend your foot. You're actually extending your foot. It's referred to as plantar flexion because it's more or less flexion in the direction of the plantar surface of the foot, right? The plantar surface is the sole of the foot. So that is plantar flexion. And the opposite, dorsiflexion. Right. We went through adduction and abduction already, but in the case of the hand, right? If you move your hand as the diagram has it here, this one, you're removing your hand away from its midline, right? Consider a midline of the hand starting from the tip of your middle finger all the way to your wrist, right? That is the midline of your hand. If you move away from the midline, that is abduction, right? But moving it in the direction medially is referred to as ulnar deviation, because on the medial side of your forearm, you have the ulnar bone. Your forearm has two bones, right? The ulnar and the radius. The ulnar is on the medial side, or the inner side of your forearm, and the radius is on the lateral side, or the outer side of your forearm. So any direction you move your hand, if you move your hand towards the ulnar, is referred to as ulnar deviation. Moving it towards the side of the radius is referred to as radial deviation. Make sure to stop me if you have any questions or you need anything clarified, right? Next we are, extension, flexion, and hyperextension. Hyperextension of the digits, it basically, you're moving the fingers beyond normal extension, right? So that hence the name hyperextension, greater extension. We went through flexion, but flexion decreasing the angle. If you can see here, when you flex the fingers, you're decreasing the angle between the fingers and the palm of the hand. Palmar abduction. Okay, so this term refers specifically to a movement of the thumb, right? So palmar abduction, you're moving the thumb in the direction of the palm, right? And above, you're moving the thumb you're moving the thumb in the direction of the palm and above the plane of the hand, right? So if you do that movement now, you realize your thumb is moving up. So it's moving above the regular plane or the normal plane of the hand and towards the palm. So palmar abduction, right? Here we have flexion and extension of this joint in the thumb. Flexion, decreasing the angle between this part of the thumb and this part. Extension, increasing the angle between here and here, right? radial abduction. So if you move your thumb, like you're spreading your thumb away from your hand, moving your thumb away from your hand moves your thumb in the direction of your radius, right? Hence the name radial abduction, because you're also moving it away from the midline. Anteposition, and before I do that, let's look at opposition, opposing the thumb and finger. So if you move your thumb and bring it towards your little finger, that action is referred to as opposition. You could do it to your other fingers as well. That is opposition. Hence why you hear that humans have opposable thumbs. That's where the term comes from, opposition. And this movement is actually quite important because it allows us to have what is referred to as a precision grip, as we'll come to discuss later on in the lecture, right? And retroposition and anteposition. Anteposition is the position that the thumb is in opposition. Retroposition refers to the moving the thumb back to its resting point, so to speak. So coming out of opposition is retroposition. Following?
Sorry, you said opposition allows us to have precision grip. That's what you said?
Yeah.
Okay.
Okay, cool. All right, so this is just a table summarizing what we have went through just now. This is for your use when you're going over the lecture stuff. Okay, so before I ask questions, do you all have any questions that you want me to clear up or anything?
For the radial for the radial abduction, when the hand is to the side, you said it moves away from the midline. So why wouldn't that be lateral? For F.
For which one is it?
No, wait, go back. Yeah, for F.
Well, it is lateral. You are moving you're right. You are moving your thumb laterally.
So it's radial abduction or lateral abduction?
No, not exactly, because you can't really use lateral with abduction, because remember, medial refers to the midline and lateral is further away from the midline, right? The action of abduction is already moving away from the midline. So saying lateral abduction is kind of repetitive.
Oh, so where does the radial come in again, please, if you could say that over?
Right. The radial refers to the radius bone, which is the outer bone on your forearm. So if you have your hands in anatomical position, with your palms facing forward, as I showed you just now, you have two bones in your forearm. One that is more medial or inward on the inner forearm, that is your ulnar. The other one, which is more lateral, is your radius. Right?
Oh, and the thumb is attached to that one.
Not quite, but moving the thumb in that direction moves it in the direction of the radius, hence is radial abduction.
Oh, okay, I get it now. Thank you.
Yeah, no problem. All right. Any other questions? No questions? Okay, I have some questions then. Okay, so we have two questions here. I'll give you, let's say, 30 seconds to attempt it, and then I'll go through them with you. All right? Okay, so circumduction involves the following combination of movements: A, flexion, B, abduction, C, extension, or D, rotation. Does anybody have an answer for this question?
Would it be D, since it's moving in D? Yeah.
That is correct. Yes, the answer is D, right? To explain it, try to sit in a position where basically just raise your leg a little bit, right? Sit in a position where your foot is off the ground, off the floor, right? Now circumduct your foot, right? Move your foot in a circular motion, right? At one point, your foot is extended, right? The leg is extended. The angle between the leg, which is the lower part of the lower limb, and your thigh is increased. So at that position, you would have extended your leg, right? If you continue the motion, you'd realize that your foot now reaches out laterally. Your foot is now moved laterally, right? So your foot is moved away from your midline, which is abduction. So abduction does occur in circumduction. And if you continue that movement, at another point, the angle between the leg and your thigh would have decreased, so we could say flexion has occurred. So flexion is also a part of circumduction, but nowhere throughout that motion you're rotating your foot. So rotation is not involved in circumduction. All right. And the second question, which statement is true? The term protraction and retraction are applied to movements of the A, shoulder and mandible, B, hips, C, legs, or D, abdomen. Anybody has an answer for this question?
A.
Yes, A is correct, right?
Would
The
it
mandible.
be A, shoulder and
Yes, A is
mandible?
correct. Yes, A is correct, right? We went through the movements of the shoulder blade just now, and protraction and retraction was one of them. And the mandible is the lower jawbone, right? You could actually move that bone forward, like push it forward, which is protraction of the mandible, and then you could bring it back to normal position, which is retraction. But your hips, legs, or abdomen, you can't do any of that, right? You can't protract your hip or retract your hip, etc. Right? So A is correct. All right, those are just the answers there. Okay, two more. Attempt these and then we'll go through them, right? Okay, so which statement is false? Movement of the foot include A, plantar flexion, B, dorsiflexion, C, supination, or D, inversion. So which of those options is not correct? Is not a movement of the foot.
C.
That is correct. C, you can't supinate your foot, right? It's impossible for you to, that range of motion is just not possible in the foot, right? And the other, which statement is true? When the foot is in an inverted position, so inversion of the foot, right? The sole of the foot is directed A, medially, B, laterally, C, proximally, or D, distally.
Would it be B laterally?
I say A.
All right, so inversion and eversion, right? The question said when the foot is in an inverted position. So they're talking about inversion of the foot, right? In the inverted position or inversion, you're moving the sole of your foot medially towards your midline, right? So you're moving it in, hence inversion, right? So you could think of that when thinking of inversion, moving the sole of your foot inward. Eversion is moving the sole of your foot laterally or outward, right? So the correct answer to this question is A, medially. Everybody understand? Any questions? Anything I need to clarify? Or you're okay?
I'm okay.
Everybody else okay? You can type in the chat if you don't want to unmute your mic and stuff. I just want to make sure that you understand the questions and what we've covered so far and stuff. Okay, for the sake of time, I'll continue, but I encourage you to ask me any questions that you have, right? Okay, so those are the answers, supination and medially. Right, now we're going to distinguish between what is referred to as the axial skeleton and what is referred to as the appendicular skeleton, right? The axial skeleton refers specifically to the skeleton of the head, neck, and trunk. Trunk being your abdomen, trunk being your thorax and abdomen, right? So that would include skull, the vertebral column, rib cage, etc. Right? The appendicular skeleton, however, refers specifically to the bones of your limbs, your both upper and lower limbs, because those are your appendages, right? Now we're getting into the actual upper limb, right? So the upper limb in humans is built for manipulation and for doing manual activities, right? It projects from the axial skeleton, or it projects from your trunk, and is therefore freely movable. Most of the manipulative ability of the upper limb comes from the most distal part of the upper limb, which is a hand, right? Your hands are very movable. It has the greatest degree of motion of the upper limb. The weight-bearing limb is referred to as the lower limb, sorry. Hence, the upper limb is spared for grasping, holding onto stuff, etc. I mentioned previously that because we could oppose our thumb, we could use what is referred to as the precision grip. We have 3 types of grip in total, the power grip and hook grip, but those are seen in primates, right? Only humans are capable of the precision grip. And this precision grip is very important because it allows us to hold onto instruments, a pen, for you to take your notes right now, and is responsible for us, for how advanced humans are. Because without the precision grip, we wouldn't have been as advanced as we are now, because we wouldn't have been able to do the things that we are able to do now, right? Right. So what you're looking at here now is the bones that attach the upper limb, well, the bone that attaches the upper limb to the trunk. And this is referred to as the pectoral girdle, right? The pectoral girdle is a limb girdle, the limb girdle of the upper limb. A limb girdle is just defined as bones that articulate or attach the limb to the axial skeleton, right? So here we could see our clavicle, and here we could see the scapula. These two bones make up the pectoral girdle. The humerus is in this diagram, but it doesn't form the pectoral girdle, right? These two bones make up the pectoral girdle, right? All right, I said that previously, the upper limb is connected to the trunk by the pectoral girdle. It might also be referred to as the shoulder girdle. It's composed of two bones, the scapula, posteriorly, which is the shoulder blade, right? And the clavicle anteriorly, which is your collarbone. Those two bones, the scapula and clavicle, are connected to each other by what is known as the acromioclavicular joint. The clavicle is attached to the axial skeleton by the sternoclavicular joint, right? This joint is the only joint that connects the upper limb to the axial skeleton. So your entire upper limb is only connected to your axial skeleton via that one sternoclavicular joint, right? The primary function of your shoulder girdle is for muscle attachment, and that allows for the range of motion of the arm and forearm, right? Because the muscles are attached, and those muscles allow us to move our arm and forearm, right? All right, so this is just a posterior view of the pectoral girdle. We can see the clavicle here, but that's on the anterior of the body, and you can see the posterior surface of the scapula here, right? Behind the body, and the posterior of the body. Right. Now we're going into the different parts of the upper limb, right? So the upper limb, for descriptive purposes, is divided into 4 parts. You have the shoulder region, you have the arm here, the forearm, and then we have the hand. Right? The shoulder region consists of the axilla, or your armpit, the scapular region, which is posterior, and your breast or pectoral region anteriorly. The bones of the shoulder region are the bones of the pectoral girdle, or the shoulder girdle, the clavicle, and scapula. Arm refers specifically to the part of the upper limb between the shoulder and your forearm. So you would hear people referring to the entire upper limb as the arm, but that actually isn't anatomically correct, right? The arm is solely specific to the part of the upper limb between the shoulder and the elbow, or the cubitus. Cubitus is just a term, or anatomical term for elbow, right? And the bone that is in the arm is your humerus. The next part of the upper limb is your forearm, and that occurs between the elbow and the wrist, right? Elbow being superior, wrist being inferior, right? As I said before, previously, the forearm has 2 bones. You have a radius, which is on the lateral side, and you can see it here. And you have the ulnar, which is on the medial side, and you can see this one here. Right? Lastly, you have the hand, right? And the hand is composed of the wrist or carpus, the metacarpus, which is your palmar region, the palm, and your digits. The digits refer to your thumb and your fingers, right? Right, so getting into the wrist, your hand, right? Part of your hand. The wrist actually has 8 individual bones, right? And those 8 bones are arranged in 2 rows, each row having 4 bones. The names of the bones of your wrist are the scaphoid, lunate, triquetrum, pisiform, trapezoid, capitate, and hamate. This list here. And these bones are referred to as the carpal bones. So those are the bones of the wrist, right? These bones articulate or connect with each other via intercarpal joints, right? So the name kind of makes sense, right? Intercarpal joints, so joints in between carpal bones, right? They articulate with the radius. Well, at least some of the carpal bones articulate with the radius to form, you can see it here on the schematic diagram, and that forms the radiocarpal wrist joint, right? The carpal bones actually don't form a joint with the ulnar. They only form a joint with the radius, right? That's something you want to take note of. And they also articulate with the metacarpals, the bones of your palm, to forming carpal-metacarpal joints, right? So it's joints between carpal bones and metacarpal bones, right? Following so far?
Yeah. Yeah, so far.
Okay. Right. This diagram breaks down the bones of the hand so that you can see them properly, right? And this kind of green color we have here, these are your carpal bones, right? And I'll make sense of how they are arranged in the next slide. Here we have the metacarpals, or the bones of your hand, right? Then you have the bones of the digits. These are referred to as phalanges, right? So you're seeing here proximal, middle, and distal. Remember I was saying that proximal refers to closer to the origin and distal further away from the origin, right? So in the grand scheme of things, right, this bone is more proximal than this one and this one. So this is referred to as the proximal phalanx, right? And this one is more distal than the rest. So this is the distal phalanx, or plural phalanges, right? The thumb, so while the digits, your fingers, sorry, have 3 phalanges, the thumb only has 2, a proximal one and a distal one. There's no middle phalanges like the rest of the fingers, right? Like the fingers, sorry. Right. So it's important for us to know the different bones of the wrist and how they're arranged, right? So from lateral to medial, this is how they are arranged, right? So we have 2 rows, a proximal row and a distal row. So this row here, these 4 here, are in the proximal row. These 4 here are in the distal row, right? This green bone is the scaphoid. Just medial to the scaphoid, we have the lunate. Medial to that, we have the triquetrum. Medial to that, we have the pisiform bone. We're going back lateral in the distal row now, right? This is the trapezium. Here we have the trapezoid bone. In this kind of pinkish color, purplish color, we have the capitate. And here the hamate, right? So a good mnemonic or memory device to remember the bones of the wrist and how they are arranged is some lovers try positions that they can't handle, right? Some, the essence some stands for the scaphoid, and L in lovers, lunate, and is actually arranged, the mnemonic is actually arranged from medial to lateral and then medial to lateral, right? So some, scaphoid, lovers, lunate, triquetrum, positions, pisiform, and then we're going to the distal row now. We're going back laterally. Trapezium, well, that, trapezium, they, trapezoid, can't, capitate, handle, hamate. So the first letter of each word of the mnemonic stands for the first letter of each bone of each carpal bone. All right? Any questions? You're following, right?
Yes.
Okay.
Yeah, I'm following.
Okay, cool. All right, this is the same, well, a posterior view of the hand, right? You can see the same bones, but just from the posterior view. We have here the scaphoid, here's the lunate, here's the triquetrum, here's the pisiform. Come back laterally. Here's the trapezium, here's the trapezoid, here's the capitate, and here's the hamate, right? All right, now we're getting more specific into the different bones of the upper limb, right? Why is it important for us to study the bones? Besides the fact that they're going to ask you questions about the bones, it's important for us to have a proper understanding of the bones of the upper limb, so that we could then understand the muscles and the movements, the range of movements, etc. Also because we're going to be doctors in the future and fractures do occur. So understanding the bones will allow us to properly understand how to treat fractures, etc. Right? So the upper limb contains 32 bones. Right? You have one clavicle or collarbone. You have one scapula or shoulder blade. You have one humerus, which is the bone in your arm. You have two bones in your forearm, the radius and the ulnar being medial and the radius being lateral. You have 8 carpal bones, making up the bones of the wrist, and we went through those just now. You have 5 metacarpal bones, and you have 14 phalanges, right? The first bone that we're getting to is the clavicle. So the clavicle is a long bone, and it's slightly S-shaped, right? It lies horizontally on the anterior portion of the body, the anterior surface of the body, and it's located just at about the junction of the root of the neck, which is the starting point of the neck, right? And the trunk. It articulates or connects or joins, right? Medially with the sternum. The sternum is commonly referred to as the breastbone, right? So this, the bone in the center of your thorax as the sternum. And the clavicle articulates with the sternum and the first rib cartilage, right? It also articulates laterally with what is known as the acromion process. Is your clavicle, right? The clavicle is also subcutaneous, as in it's just beneath the skin, right? And if you start medially, like if you those two bumps on like just below your neck, that's actually where the clavicle articulates with the sternum, right? If you feel like palpate, which means to feel with your hands, if you feel along your clavicle and you continue laterally, you could actually feel the entire extent of your clavicle, more or less. But you could actually feel the most of, if not the entire clavicle, right? I'll go through the different features of the clavicle just now. All right, so there's some facts about the clavicle. It is the only it doesn't contain bone marrow. It doesn't produce bone marrow, right? It is subcutaneous throughout its entire extent. Well, let's discuss that and palpated the clavicle. It is actually the first bone to begin ossifying. Ossifying refers to development of the bone, right? But you would do ossification in histology later on, right? It's actually the first bone to start ossifying, and it begins between the 5th and 6th week of intrauterine life, and is the last bone to complete ossification at about 25 years, right? It is the only long bone that ossifies by two primary centers. So centers being the ossification centers, which is regions that are responsible for ossification. But you get to know more about ossification later on. Right, it's the only long bone that ossifies in membrane, except for the medial end, right? And that ossifies in cartilage. Right, so for descriptive purposes, the clavicle is divided into three parts, right? Throughout anatomy, you'd realize that everything is divided so that it could be described properly and efficiently, right? So the clavicle is divided into three parts. We have two ends, a medial end and a lateral end. Here, we could see the medial end of the clavicle. And here is the lateral end of the clavicle, right? The lateral end is referred to as the acromial end, right? Because this side articulates with the acromion process of the scapula. Hence, it's called the acromial end, right? The sternal end or the medial end articulates with the manubrium of the sternum. The manubrium of the sternum is just the upper part of the sternum, right? But we'll get into that, the different parts of the sternum, etc. Yeah, so since it articulates with the sternum, is referred to as the sternal end of the clavicle, right? It articulates with the sternum to form the sternoclavicular joint. But this end also articulates with the first costal cartilage, your first rib cartilage, right? Via a ligament, the costoclavicular ligament. Next, you have the shaft, which is this entire extent here, right? The shaft is curved, slightly S-curved, as we said previously. The medial 2/3 is round and convex forward, right? Throughout anatomy, you'd realize that things are often divided into thirds for us to be able to describe it properly. The shaft of the clavicle is divided into a medial 2/3 and a lateral 1/3. Let me get a pen. At about right, at about that from like this point here to here makes up the medial 2/3 of the shaft of the clavicle. Here is the lateral 1/3 of the shaft of the clavicle, right? So this medial 2/3 is round and actually convexes forward, right? So this is a convex curvature here, right? So forward is a convex curvature. The lateral 1/3 is flattened. You can see it's kind of flat compared to the sternal end. It's flattened from above downward. So it's kind of angled downwards, right? And the curvature at the front is a concave curvature, right? Along the inferior surface, which you can't see here yet, but on the inferior surface, we have a longitudinal groove in the middle third of the shaft of the clavicle. I'll show you that just now. Okay, so this slide repeats what I said just now for some reason. Right, again, the medial 2/3 is round and convex forward, and the lateral 1/3 is flattened and concave forward, right? So there's a concave curvature here. Right, it's important for us to be able to orient ourselves in, for example, well, in spotter exams, right? You'll have to be, they would ask you questions about a specimen. So they would have, like, in this case, a clavicle on the table, and they would ask you questions about the clavicle, but you can't touch or move the clavicle to see different features or etc. So you have to be able to orient it in your mind, right? And how we would do that is by ensuring that the different ends and surfaces are facing where they're supposed to be facing, at least in our mind, right? So we would make sure that the sternal end is directed medially and the acromial end is directed laterally. As long as you do that, that's half of the orientation done, right? The next thing you want to look at is the surfaces. You want to look at the superior surface, which is here. This is actually a superior surface of the clavicle, or a schematic diagram showing the superior surface of the clavicle. And this is the inferior surface, right? It's very easy to distinguish between the superior and inferior surface. Well, relatively easy, right? It depends on how good the specimen is, etc. But on the inferior surface, you could see that we have various grooves and features, right? So laterally, we have the trapezoid ridge, right? And this allows for, this is a ridge that allows for articulation of a ligament, right? The trapezoid ligament. Here we have a tubercle, a conoid tubercle, right? And a tubercle refers to a rounded projection from a bone, right? So anytime you hear tubercle, it doesn't matter what bone it is, it's a rounded projection from that bone, right? So this tubercle on the inferior surface of the clavicle is the conoid tubercle. You could kind of see it from the superior view in actual specimen. It kind of protrudes slightly in the superior view right here, right? I'll show you in the diagrams coming. Here we have a groove known as the subclavian groove. And this groove allows for the insertion of a muscle, the subclavius muscle, right? That is in the middle third of the shaft of the clavicle. So in the middle third, I said medially just not by mistake. In the middle third of the shaft of the clavicle, on the inferior surface, you have the subclavian groove. And the sternal end, we have a rough impression right, and the inferior surface. That rough impression allows for the costoclavicular ligament. Anybody remembers what that ligament, what I said that ligament does? Okay, so remember I said that the sternal end of the clavicle articulates with the sternum and the first costal cartilage, the first rib cartilage. Well, it articulates with the cartilage via a ligament, the costoclavicular ligament, that is attached in this or on this rough impression here. All right. Give me 1 second. Okay, let me just go through the features of the clavicle here, right? So in this is a anterior view. So this is how the clavicle looks in an anterior view. Here we have the sternal end, and here we have the acromial end, right? These blue, like this little blue highlight, is just where the clavicle would articulate, right? So here is the articular surface of the clavicle where it articulates with the acromion process of the scapula, right? Here is the trapezoid ridge, well, or line, trapezoid ridge or line. And here is the conoid tubercle, right? You can kind of see, this is an inferior view, right? And in the superior view, you could kind of slightly see the conoid tubercle protruding just above the red laser point, right? And you have this subclavian groove here in the middle third of the shaft of the clavicle. And closer to the sternal end, we have the rough impression for the costoclavicular ligament, right? And this diagram has the same features. Right. Could anybody tell me what view this is? What side, which clavicle is this, right or left? And what view we're looking at?
The right clavicle?
Right,
No.
that is correct. Yeah.
Oh, yeah, right. The
What?
No, I don't know the view. Is it anterior?
No, it's not anterior, right? It's actually the
Left? I don't know.
is actually the inferior surface, right? Remember that the inferior surface has the conoid tubercle. It's kind of is not really as easy to see because it's an actual clavicle, right? It's not as exact as how it is in schematic diagrams. But here you have the conoid tubercle. You could barely see the trapezoid ridge, but you could see here is rough. That rough impression is for the costoclavicular ligament, right? But this is the right clavicle. How I would know that is because the sternal end is directed medially, right? If you turn your body, if you mentally turn your body in the position that this clavicle is in, you would realize that when you turn your sternal end to face the same direction that it is faced in this diagram, you'd realize that it has to be your right clavicle, right? And the lateral end, the acromial end, faces laterally, right? So you have to position yourself sometimes in your mind, or you could actually turn around, because I do it sometimes. You could actually turn yourself or orient yourself to see what you're looking at, to understand what you're looking at properly, right? And that is important for spotter exams because you can't touch the specimen. Right, now we get into the ossification, right? The ossification of the clavicle occurs at 4 ossification centers, right? 2 of those are primary centers, and the other 2 are secondary centers. So you have 2 primary centers located in the shaft of the clavicle, and then you have 2 secondary centers at the ends of the clavicle, right? And as I said before, ossification of the clavicle begins at about 5 to 6 weeks of intrauterine life and completes at about 25 years, right? And the clavicle is the first bone to begin ossifying in fetus. Right, any questions about the clavicle? Anything you need me to go over? Any questions? No questions?
Not from me.
Okay. Right. I have questions for you. Right. In the diagram below, the ligaments associated with the areas labeled A, B, and C, respectively, are. Right. So basically asking what ligaments attach to these different positions on the clavicle. Right. So take a 30 seconds, just think about it, and then we'll go through it together. Okay, does anybody have an answer?
A? Question mark?
Okay, let's see, right? This impression here is the rough impression that allows the clavicle to articulate with the first costal cartilage. And the ligament that does that is the costoclavicular ligament, right? So that being said, it can either be A or C so far, right? B is the conoid tubercle, right? And remember I said the conoid tubercle allows for the conoid ligament to attach, right? C is the trapezoid ridge, right? And allows for the trapezoid ligament to articulate with what is known as the coracoid process on the scapula, but we'll get into that just now. So C is the trapezoid ligament and B is the conoid ligament. So the answer is actually C.
So C has a spelling error.
It does?
Costoclavicular.
Oh my bad. I
That's
apologize.
why I only tell it because I'm like, it's a trick question.
No, I apologize. I sincerely apologize. That's supposed to be costoclavicular. My bad. That's my fault.
That's okay, because that's why I said A, because I'm like, it's spelled incorrectly.
I didn't even realize that. My bad. Sorry. I'm so sorry. But costoclavicular. And well, C is the trapezoid ridge. So the trapezoid ligament attaches, right? Okay, another question. What is the joint forming the only point of articulation of the upper limb bones with the axial skeleton? What y'all think?
I want to say D.
And that is correct. That is very correct, right? Remember, the sternal end of the clavicle articulates with the sternum, hence the name sternal end, via the sternoclavicular joint. And the names of joints basically tell you what they're joining, right? So sternoclavicular, it's joining the sternum and the clavicle. Acromioclavicular, that is the acromion with the scapula and the clavicle, right? But yes, D is the correct answer here. Right, now we're going into the last bone that we will do for this class, which is the scapula, right? The scapula, commonly referred to as the shoulder blade, is a relatively large bone, and it's flattened and kind of triangular shaped, more or less, right? Is located in the upper part of the posterolateral aspect of your thorax. So let's break this down, right? The upper part, postero, so posterior on your back, lateral, right? So it's posterior and lateral, hence posterolateral aspect of the thorax, right? It overlies the 2nd to 7th ribs, right? Is divided into 4 parts for descriptive purposes. You have a body, and then you have 3 processes: the spinous process, the acromion process, and the coracoid process, right? Right. So let's talk about the body of the scapula, right? The body has 2 surfaces: a costal surface, which is this surface here. Costal surface is the anterior surface of the scapula, and you also have a dorsal surface or posterior surface. So this is the posterior surface of the scapula, right? So these are the 2 surfaces of the scapula: anterior or costal, posterior or dorsal, right? And the reason why it's called the costal surface is because that surface is overlying the ribs, right? It also has 3 borders, right? You have a superior border here, along here. You have a lateral border along here. And you have a medial border, right? So the medial border is on the medial side of the scapula. The lateral border is on the lateral side of the scapula, right? You also have 3 angles. You have an inferior angle, which is here, this point here. And the angles are formed where the borders would meet, right? So where the medial and lateral border would kind of converge, would produce the inferior angle. You also have a superior angle. So where the medial border and the superior border would kind of meet, would produce the superior angle, right? Superior because it's superior on the scapula, so it's above on the scapula, and inferior because this is on the lower portion of the scapula, right?
Okay, quick question. The dorsal view means the back, right?
Yes.
So the section that is labeled spine of the scapula, that would be face, and the acromion that would be what's attached to like the rib cage, or like going towards the ribs.
No, no. Remember, the costal surface is what would be above the ribs, right? So these two processes would actually be moving away from where the ribs are, because it's on the back, right? So these processes stick out backwards.
All right, hold on. Let me ask another question then.
Yeah, no problem.
Which the dorsal view, which scapula is this? Left or right?
That is the right scapula. I'll show you how I knew that, right?
Okay.
But after we go through the different features. Yeah. Good question. Where was I? The angles, right? So this is the superior angle here, your inferior angle here, and you have a lateral angle, right? This lateral angle actually forms this glenoid fossa here, right? So this is actually the lateral angle of the scapula right here, right? Just to go through the different features. Actually, I'll come back and show you the features. Right, so this view that we're looking at here, this is an actual scapula, and this view that we're looking at here is the anterior view or costal view, right? Here are two of the processes. Here you have the coracoid process that you could properly see from the anterior view, and the acromion process is on the posterior, right? But this is the costal surface, right? Right, so the coracoid process, which I showed you just now, is like a shaped similar to a bird's beak to some extent, right? And it arises off of the upper border of the head of the scapula, right? The head of the scapula refers to the lateral angle. Remember, I showed you that the lateral angle is this entire portion of the scapula here, but it forms the glenoid fossa, right? So here is the lateral angle. So you could properly see the coracoid process arising from the upper border, the superior border, and projecting looking similar to a bird's beak, right? Next, we have the acromion process. So this process projects forwards, almost at a right angle from the lateral end of the spine. And I'll show you that just now, right? The medial and lateral borders of the acromion are continuations of the upper and lower lips of the crest of the spine of the scapula. Let me show you what I mean here, right? So on this scapula, question? Okay, so this is the posterior view of the scapula, right? In this view, we could properly see this process, which is the spinous process, or the spine of the scapula. Let me get a better diagram. Let me use this diagram. Right. Here you can see the spine of the scapula. And continuing from the spine of the scapula, we have the acromion that projects forward, right? So it's kind of bent and projecting forward anteriorly, right? So here, along this edge here, is the crest of the spine, right? This border that I'm tracing here is the upper lip of the crest of the spine of the scapula. This lower border is the lower lip of the crest of the spine of the scapula, right? The upper lip continues into the acromion process to form the medial border of the acromion. So this border here is the medial border of the acromion. The lower lip continues to produce the lateral border of the acromion. Like it continues and produces the lateral border of the acromion, right? Right. So here we have the spine again. We have the upper lip continuing into the acromion. The acromion ends at about this point here, but it articulates in this diagram. It's articulating with the clavicle. But let's focus on the acromion here, right? So the upper lip continues to produce the medial border of the acromion, and the lower lip of the spine continues to produce the lateral border of the acromion, right? Also in this view, right, we could properly see the spine, right? The spine of the scapula, you can see that it divides the dorsal view, the dorsal surface of the scapula, into more or less two parts, right? It divides it into a superior third and an inferior 2/3, right? This superior third is a fossa, right? There's a fossa here, and a fossa refers to just a slight depression in the bone, right? So there's a slight depression above the spine of the scapula that is known as the supraspinous fossa, right? And the name makes sense. Supraspinous, so superior to the spine, and it's a fossa. So it's a fossa superior to the spine of the scapula. So supraspinous fossa. Below the spine of the scapula, we have the infraspinous fossa, right? Fossa is a kind of depression in the bone. Infraspinous because it's inferior to the spine of the scapula. Following?
Yes.
Nice. And I have that written here. So the dorsal surface has a shelf-like projection, which is the spine of the scapula or the spinous process. And it's located at the junction of the upper 1/3 and the lower 2/3 of the dorsal surface of the scapula, which I mentioned just now. It divides the scapula into two parts, the upper supraspinous fossa and the lower infraspinous fossa, right? Okay, so this view that we have here is a lateral view of the scapula. We could properly see the body here, well, extending all the way up here, right? We could see the acromion or the acromion process. We could kind of see the spine and the shelf-like projection. And here we could properly see the coracoid process. This fossa right here, remember that I said a fossa is a slight depression in the bone, right? So this fossa right here is the glenoid fossa. Here is where the humerus would articulate with the scapula, to form the shoulder joint or the glenohumeral joint. But we'll go through the humerus and the other bones in next class. Right. Just above the glenoid fossa, you could kind of see it, barely, but you could kind of see it, is a little projection off of the glenoid fossa, right? That is the supraglenoid tubercle. Let me show you the right. So you could see a slight raise just above, a slight projection just above the glenoid fossa, and that is the supraglenoid tubercle. Similarly, inferior to the glenoid fossa, we have the infraglenoid tubercle. right? And in this lateral view, you could properly see the lateral border, etc. Another thing I forgot to mention, along the superior border, we have a notch here. And this notch is the suprascapular notch, right? Which makes sense again. Suprascapular, it's along the superior border of the scapula, right? And it's a notch. And we actually have a nerve that runs along this notch, but you'd see it as we go through the upper limb. Right, so how we would properly position the scapula, right? How we would orient the scapula, for example, in a spotter exam. You want to make sure that the spinous process is directed posteriorly, right? Then you want to make sure the glenoid cavity faces laterally, anteriorly, and slightly upwards, right? The coracoid process has to be directed anteriorly. So just now you asked me which. Okay, well, let's look at this scapula, right? If we direct the glenoid fossa laterally and the spine of the scapula faces posteriorly, we would realize that this is a left scapula and we're looking at the posterior view, right? If you orient yourself in such a way that the glenoid fossa, or the lateral angle of your scapula, faces in the direction of the lateral angle of the scapula on the diagram, you'd realize that you're looking at a left scapula. Following?
Yes.
Nice. So that is how I knew what scapula I was looking at when you asked me. Okay. Right, the ossification, right? So the scapula ossifies in cartilage, and it has 8 ossification centers, one of which is primary, and the remaining 7 are secondary centers, right? So the primary center occurs in the body, and then you have 2 centers in the coracoid process, 2 more centers in your acromion process, and then you have 1 center for each of the following, right? You have 1 center along in the medial border, 1 at the inferior angle, and 1 at the lower part of the rim of the glenoid cavity. And ossification of the scapula begins at about the 8th
Hello?
I think he's stuck, so let me just quickly message him to see what's up,
Oh.
right? Hello?
Oh, you're back.
You okay?
Okay.
Yeah, I don't know what happened just now. My connection just dropped. You're hearing me properly now, right?
Yeah.
Okay, great. What was the last thing you heard?
Ossification commences in the 8th week of intrauterine life.
Great. Well, yeah, that is it for the ossification. Are there any questions about the scapula? Anything I want to go over, run through, break down, anything like that?
No.
Okay, so no questions. Which of the following statements best describes the scapula? Is it A, it usually overlies the 2nd to 9th ribs? B, the spine continues laterally as the coracoid process? C, the suprascapular notch is found on its spine? D, it provides attachment for both head of the biceps? Or E, most fractures involve the body? Okay, so I will go through this question with you, right? Let's look at A. Wait just a minute. Right. It usually overlies the 2nd to 9th ribs. Remember that we said that the scapula is along the upper part of the posterolateral, the upper posterolateral part of the thorax, right? And it overlies the 2nd to 7th ribs. So A can't be correct here. B, the spine continues laterally as the coracoid process. That isn't correct, right? Because we know the spine continues to form the acromion process. Right?
Oh, sorry, I thought I was unmuted. Right.
Okay, cool. C, the suprascapular notch is found on its spine. Is that correct?
Wrong.
Say that again?
Wrong? It's on the wait, hold on. It's on that top part, like before you get to the acromion process. And so that's where the
Right.
little bit is. So that's wrong, I think.
Right. It's along the superior border.
That's it, the superior border. Yes.
Right, right. D, it provides attachment for both heads of the bicep. This is actually the correct answer. I didn't expect you to know that now, but this question was just to go through the options so that you know it overlies the 2nd to 7th ribs. The spine continues. Somebody was saying something?
Oh, I was just saying,
Right. And the suprascapular notch is found on its on the superior border, sorry. But it does provide attachment for both heads of the bicep muscle. Right?
But had you mentioned any muscles when you were going through the scapula?
No, I didn't. I was just showing you the features of the bone. But this is just I just put this question here to really just to go through A, B, and C.
Oh.
Right? But this is something that you could know now for future. So the scapula does in fact provide attachment for both heads of the biceps. Right? Just something for future notes.
Okay.
Okay, well, I might have given away the answer to this question, explaining the last question, but the spine of the scapula is continued laterally as the I just mentioned it. E is correct, yes. It continues as the acromion or the acromion process of the scapula.
I'm learning.
Say that again?
I was saying I'm learning. I was gonna guess, but then I was like, no, it's E.
Yes, that's nice. It's E. I'm glad you're learning and understanding. Right. The weight of the upper limb is transmitted to the trunk via the A, trapezius muscle, B, coracoclavicular ligaments, C, clavicle, or D, deltoid muscle? What do you all think?
You hadn't gone through this, right?
Not directly, but indirectly, right?
Oh, so we have to decipher it now. Okay, so the weight of the upper limb is transmitted to the trunk. So that means,
Okay, let me help you a little bit. Instead of thinking of it as the weight of the upper limb, try to think of force is transmitted from the upper limb to the trunk via the.
so it would be whatever is closer medially going towards the trunk.
It will be what joins the upper limb to the trunk. Yes, if that's where you're coming from. Yeah. One of the roles of the skeleton is for force transmission, right? So it transmits force from. Okay, let me just explain the question, right? So
Okay.
let's say, for example, you fall on your outstretched arms, right? When you fall, there'd be a force that runs up the bones of your upper limb and runs into your axial skeleton. That is done so that the force isn't experienced in one location alone. Because if that occurs, then your bones would fracture, right? Or some bone would fracture. What this question is essentially asking is what bone articulates the upper limb to the axial skeleton.
So the clavicle.
Right, that is correct. The clavicle.
So okay, so this question is structured to. This is a question. The question is kind of structured to throw you off because all the options except for C are the muscles and the ligaments. But
Exactly.
you're saying basically the force is transmitted through the bones.
Yes.
So
Yes.
so by elimination it had to be C even if you didn't know.
Yes. Right.
Okay.
But we know that the clavicle is the only bony attachment, the only bone that attaches the upper limb to the axial skeleton, right?
Right.
So the answer there is in fact C. And that actually concludes our class today. That was the last question. So you've successfully completed your first anatomy class. Yay! How was class? I hope you all enjoyed it.
That was very good. I learned a lot. Thank you.
That is great. That is lovely to hear. You have any other questions? Anything you want me to clarify? Anything like that?
Not right now. But since we paid for this session, if when I go through the recording again and go through, my own notes and everything, I can ask the questions in the group? Or
Of
should I
course,
just
yeah.
okay,
You
okay.
could ask the question. You could even message me privately if you see fit.
Okay. Just